So, hello everyone and welcome. I am thrilled to be here today. My name is Dr. Carley Akehurst. I am a naturopathic doctor living and working in Vancouver, BC. I'll go over my background and approach later on in the presentation, but I just wanted to start by saying a big thank you. It's a privilege to be here to share and speak on a topic that I am so passionate about. So welcome. Today we'll be covering interstitial cystitis, a naturopathic approach. As you can imagine and perhaps have experienced, interstitial cystitis is a term that can be sometimes difficult to say. So for the most part, I'll be referring to it as IC, but generally speaking, you can think of interstitial cystitis as a broad term that covers many different symptoms that pertain to the bladder. So I'll be speaking a little bit more in detail about that shortly. So just to cover what we're looking over today, we'll start with a welcome, introducing myself and background. I'll go over some disclosures that I have in terms of connections that I have in the community. I'll cover a brief overview of what is naturopathic medicine. My hope is that some of you have had experience with a naturopathic doctor or naturopathic medicine, but I'll give a little overview for those of you who have not. We'll then cover what is interstitial cystitis or IC. How does one develop IC? What is the microbiome? How IC and microbiome interplay. We'll introduce a concept of something called the urogenital microbiome. I'll cover current findings and research, so what's changed about our approach to IC recently and how we can use that information to get to the root cause and appropriate treatment for a patient. Towards the end, I'll cover testing options, including up-to-date testing options, treatment options, and then we'll have lots of time to cover a summary and lots of time for questions and answers. So we'll dive in. So as previously mentioned, I'm Dr. Carley Akehurst, naturopathic doctor. I've been working with IC patients and chronic bladder symptom patients for over a decade now. I own a clinic in Vancouver, which is where I am at the moment. You'll notice some of the photos throughout my presentation are taken here at our clinic. My clinic is called Clementine Natural Health. We are a natural health clinic comprised of naturopathic doctors, a medical doctor, a counselor, nutritionist, and a nurse located here in Vancouver. I'm passionate about research and education around the connection between IC and the microbiome. We'll talk a little bit more on that further, but I think this is an area that is more research is warranted, but more research is coming out almost every day in how to best support our patients and how patients can advocate for themselves in terms of getting the most up-to-date and relevant treatments. My general approach, I have a root cause approach to health, so meaning that I want to know why you have certain symptoms so that we can properly target that underlying cause and efficiently get you feeling better as soon as possible. Just a little bit about how I ended up in this particular niche. My passion for microbiome health and research really started with the birth of my first child. I was subsequently involved with a UBC project with a microbiologist from UBC's Michael Smith Labs called Let Them Eat Dirt. It was a book, a documentary, and a campaign. I have no financial associations, but if you're interested in more reading about the microbiome, particularly as how it pertains to children, Let Them Eat Dirt is a really valuable resource for that. So a few disclosures. I am a naturopathic doctor. I am registered and licensed within the province of BC. I am in good standing with the College of Naturopathic Physicians of BC, which is now called the College of Complementary Health Professionals. I own a clinic here in Vancouver. I also run an online program called the Akehurst Protocol that supports and helps patients with recurrent bladder symptoms, including IC. I have no actual or potential conflict of interest with this presentation, but I do receive an honorarium for presenting today. And during this presentation, I will reference particular testing and treatment options, some of them by brand name, However, I have no financial or intellectual interest in any of the suggestions that I make. These are merely things that I recommend and have recommended to my patients over the years that I'm really happy and excited to be sharing with you today. I'd also like to acknowledge that I'm presenting on the traditional, ancestral, unceded territories of the Musqueam, Squamish, and Tsleil-Waututh Nation. So a little bit about naturopathic medicine. In BC, naturopathic doctors are trained as primary care doctors, so similar to a family medicine doctor or a GP. In my own clinical practice, I spend significant time reviewing your whole health history. So not just the history relating to your bladder, but your hormone history, your digestive history, your family history. Those are all really important to help us paint a picture of what's happening for you and your bladder symptoms at this point in time. As my private practice is private, so it's not covered by MSP, it allows me to spend more time with you to get to know your case. But the downside of that is that it costs money out of pocket or extended health insurance coverage to see someone like me. But it allows me to take a broad overview of your health and spend a lot of time asking about those root cause concerns. I'm passionate about evidence-informed care, even when making a recommendation or prescription for something that is not standard of care. So perhaps an antibiotic prescription, I'm really looking at what's the best evidence at the moment and what's the best evidence in terms of getting the testing you need to see whether or not it's really indicated. But I get to blend the best of conventional and naturopathic treatments. When thinking about IC and through this presentation today, I'd really like you to think of it as an umbrella with multiple possible causes that need to be addressed to significantly reduce or eliminate symptoms. So if you can picture an umbrella, it's opened up, it's got all of the little spokes on it. When we think about IC, I want you to think about that as the one possible cause might be hormonal. Another possible cause might be infection. Another possible cause might be diet or digestive health. So with IC, I consider all of that: digestive health, pelvic floor health, hormone health, stress and lifestyle factors, all of that, and infection, all of that kind of comes together to determine what that root cause is. So what is IC? Many of you may know this already, many others may not, and you might be wondering if you qualify or meet the qualifications for an IC diagnosis. It's also known as painful bladder syndrome, and it is characterized by pelvic pain and frequent urgent urination. So IC is really a diagnosis of exclusion, meaning that we have ruled out other possible causes for your bladder symptoms, and the only thing that's left is something called IC. Or the only thing that we can still consider that might be part of what you're experiencing would be IC. Symptoms usually include bladder and pelvic pain, and these symptoms for certain patients can be different. So you might have bladder pain, but not pelvic, or vice versa, or you might have no pain at all. But discomfort, frequent urination, and urgency are also symptoms that we typically see that show up for this condition as well. It actually affects millions of people worldwide, and that's predominantly women. IC, as I mentioned before, is often used sort of as an umbrella term to describe those symptoms, but it is a diagnosis of exclusion. So meaning no other cause has been identified for the bladder symptoms, we give a diagnosis of IC. There are treatment options, many of which we'll cover today, but there is no known cure. As I mentioned, not all people have the same symptoms with IC. Sometimes the only symptom might be frequent urination or the need to urinate very often. Others might have burning or pain in the pelvis or the urethra where the urine comes out, but no change in the frequency or urgency of urination. What's interesting and what I'm really excited to talk about today is there is a correlation. We have this in the data to show there's a correlation between IC and conditions such as IBS or fibromyalgia. So we'll cover this more in detail on the next slide, but just as an overview, how does one develop IC? There are no official causes. So from the American Urological Association, and the Canadian Association of Urologists, there are no official known causes of IC, but in the past decade or 12 years that I've been in practice and 7 years that I've really niched down to be working with bladder patients, I've seen a correlation with the following conditions: chronic or embedded infection, dysbiosis or an imbalance in the microbiome, hormone changes, pelvic floor dysfunction, IBS or other digestive concerns like chronic constipation or loose stools, high stress or cortisol dysregulation, food sensitivities, low nutrient status, complex chronic disease, as mentioned, with something like fibromyalgia or chronic fatigue, and then more mold exposure. So we'll cover these in more detail on the next slide. So how does one develop IC? Chronic infection. We'll talk about this a little bit more in detail when we talk about some of the testing and current research. But the current way that we test for infection within the bladder is something called a urine culture. And there's two different types of urine culture. One is the standard urine culture, and the other is an enhanced culture. However, both of those types of tests are based on the same principle. You would give a sample to the lab or at your doctor's office. That sample goes to the lab where it's tested for growth of particular bacteria. There are some issues with how we test for that, especially in 2024, when we know how bacteria is behaving a little bit differently than it has in the past. So I'll cover that more in detail. However, when it comes to developing or being given a diagnosis of IC, one of the problems that we're running into is our current feeling is that, or the current thought in the majority of the medical community, including the naturopathic community, is that chronic or recurrent UTIs occur when a sterile or generally calm bladder comes into contact with a bacteria and an infection takes hold. However, we have research to show that sometimes that bacteria can become embedded, and short course treatment, which is usually the standard of care at the moment, isn't sufficient to completely get rid of that infection. So I'll talk about that more in more detail when we get to the current research chapter. I'd like to talk a little bit more about, looks like we have a question. Okay, so we'll probably cover this towards the end of our, towards the end of the lecture there in the Q&A section, but thank you for your participation on that. So talking a little bit about dysbiosis. So if I was in a room full of people at the moment, I'd probably ask for a show of hands, but I'd be curious to know who had heard of the term dysbiosis before. Dysbiosis refers to an imbalance of good and bad bacteria within the body. So for many people, this might be a new concept, but what's very interesting is that we originally thought that disease arose from a bacteria coming into contact with someone who otherwise didn't have a lot of bacteria in their system. However, what we know now is that health really requires this balance of good and bad bacteria. And so pertaining to the microbiome, or in the meaning of the microbiome, what we really know now is that we need that good and bad bacteria to be balanced in order for us to be healthy. So when it comes to, for example, having a UTI, let's say you start to develop some burning and urination, or burning on urination, perhaps some smelly urination, you go to your doctor's office, you get a culture, you're told that there's E. coli there, and you do 5 to 7 days of an antibiotic treatment. The antibiotics, while wiping out the bad bacteria, perhaps E. coli, they also can wipe out some of that good bacteria. And that can lead to, over time, a state of dysbiosis. There are things that we can do, supplements we can take, foods we can eat to help restore the good bacteria and feed that good bacteria. But if that state of dysbiosis within the bladder lasts for a long time, it can lead to chronic and recurrent bladder symptoms that could lead to a diagnosis of IC. If we have more questions about this, I'm happy to flush that out or discuss it further. But this is a really important point when it comes to looking at IC through the lens of functional and integrative medicine. So the next one is also a really important one, hormone changes. Hormone changes at midlife can play a really important role in bladder health. We know that as a person transitions through perimenopause and menopause, that there is generally a decline in sex hormones, estrogen, progesterone, and testosterone. Where this is particularly relevant to IC or bladder symptoms is when we have a decrease in estrogen locally within the vagina, the labia, in the bladder itself. What can happen is we get an increase in vaginal dryness, and we know that the dryness that happens in the vagina at that time can cause an issue with the balance of good bacteria. So I'll say that one again because this is a really important point. When vaginal estrogen declines at menopause, a person can be more susceptible to infection because that vaginal estrogen that's no longer there is important for the growth of good bacteria. So we know that patients who are offered vaginal estrogen in perimenopause and menopause are less likely to develop bladder symptoms, including IC. So that's a really, really important point, and we can talk about that one further as we go along. But if you are someone who is between the ages of 35 and 65, this is a really important avenue to explore and to perhaps discuss with your doctor whether or not some localized vaginal estrogen might be a good choice for you. So moving on to pelvic floor dysfunction. This is one that I find is always interesting when I discuss it with my patients in practice. For many patients, they'll say, oh, I've never had a child, or I had a child and I had the baby was born by cesarean, so I don't have any pelvic floor issues. Or I had a child, the baby was born vaginally, but I've never had any problems with leakage or incontinence or pressure in my pelvis. However, the pelvic floor is a hotbed of nerves, muscles, tendons, ligaments. And if you actually think about it, most pelvises aren't very big, and the bladder itself isn't very big either. So it's really important to think about seeing a pelvic floor physiotherapist or someone that can really assess whether or not there's tension in the pelvic floor that might be contributing to some of your bladder symptoms. You'd also want to see someone, again, a urogynecologist, a pelvic floor physio, a urologist or gynecologist that could assess for prolapse. So bladder prolapse, vaginal prolapse, uterine prolapse, those are all really important conditions to have ruled out. And then as well, have somebody assess for something called lichen sclerosis, which is an autoimmune condition that can show up more commonly or more often in the complex chronic disease population, but that is a condition that can cause something called vaginal atrophy that, again, is important to have ruled out and treated. But seeing someone who can do a proper assessment for that is really important. The key to keep in mind about the pelvic floor is that especially if you've had any kind of pelvic surgery, a hysterectomy or a laparoscopic exploratory surgery, it can be really important just to have somebody take a look and make sure that there's no issues or concerns there. Moving on to the next topic, which is another really big one, IBS or other digestive concerns. So I find in my practice, there's a very strong correlation between IBS, particularly IBS-C, the chronic constipation type. And that actually harkens back to the pelvic floor piece where we know that if a person does have chronic constipation, the stool is not moving properly through their bodies, it's perhaps backed up and putting more pressure on the pelvic floor. Someone has to push more to be able to get the stool out. That again puts more pressure on the pelvic floor, including the bladder. And so that can worsen those symptoms. Often with my patients, I find once we're able to get their bladder symptoms stable, we usually transition into working on what's happening with IBS or the constipation or the other digestive concerns. The nice part about that is that if we determine that there is dysbiosis there and we start to work to rebalance the microbiome within the vagina and the bladder, it often has a spillover effect of rebalancing the microbiome as it pertains to the digestive tract as well. The next piece is high stress and cortisol dysregulation. So our bladders can sometimes be a bit of a canary in the coal mine when it comes to cortisol imbalance or high stress. If you've ever given a presentation or needed, we're about to write a big test, often patients will report that they need to use the washroom more often as that sort of cortisol and adrenaline is spiking a little bit. So if this is a part of the picture, it's important to, excuse me, see someone that can evaluate that. There are also some really interesting questionnaires online that can help you look at whether or not that's a part of the picture for you. For someone that's dealing with IC, food sensitivities are probably something that they're aware of already. Most of the time, recommended foods to avoid include acidic or spicy foods, sparkling drinks, caffeine, alcohol. I find that for these, it's often a part of the picture, but not all of the picture. And for my patients, again, going back to that root cause, I want you to be able to live your life so that you can consume these things. So if we're able to look at some of the other causes of IC, many patients are able to get back to having a morning coffee or enjoying sparkling water in the evening. This is also the next piece, low nutrient status. This was something that I learned from a mentor early on, but low nutrient status, particularly in relation to vitamin D, is super important to have assessed. For anyone living in the lower mainland, we do live in the middle of a rainforest, and I find the more that I test vitamin D over the last 10 years, the more that I find that many patients are deficient. Our current reference range for vitamin D through Life Labs is 75 to 250 IUs. So looking at 275 to 250 units, that's an important gauge of where someone should be. But for myself, in my practice, I always like to see a patient who's having bladder symptoms. I find at minimum 125 to 150, and we'll talk about that a little bit more in the treatment section. And then, as I mentioned previously, there is a correlation between complex chronic disease, for example, fibromyalgia, chronic fatigue, Ehlers-Danlos, Marfan's, for example, and relation to IC. And I think for each of those conditions, the correlation is different. But at the same time, we know that often in this population, inflammation can be higher. Some of the other things that we've identified there can also be present. So working with someone and being a part of Dr. Arsenault's program, hopefully I'm certain will help you to address some of those concerns. So I'd like to talk now that we're getting into a little bit more of the nitty gritty, the science of it, but I'd like to talk a little bit more about the microbiome and why this is so important to our health, particularly as it pertains to IC and our bladder health. So when talking about the microbiome, what I am talking about is the trillions of microorganisms that live in our bodies. So this might seem a bit odd for some of you to think, wait a minute, we have bacteria, viruses, and fungus, other microscopic living things living on us and in us all the time. But it's actually a really important part of our health. And we have a global microbiome, so our overall body microbiome, but there's also particular microbiomes as it pertains to the oral microbiome, the gut microbiome, and more research is coming out every day on what bacteria make up a healthy microbiome. We know that we can identify certain bacteria that are present in people who have less illness or less disease, but we don't have an answer yet on these are the things that are important to be there for a healthy microbiome. But again, that research is coming out as rapidly as possible. The health of our microbiome affects our whole body all the way from birth and throughout our life. It controls the digestion of food, immune system health. It plays a really important role in the gut-brain connection and plays a role in other bodily processes. So as in relation to IC, there's a very important component of something called the urogenital microbiome that plays a role in the overall health of our bladders. This is also important as in relationship to the health of the vagina. So in my clinical practice, I see a regular correlation between the health of the vaginal microbiome, the bladder microbiome, and the gut microbiome. in my practice, I see that they're all interconnected. And any treatment plan or any assessment that we're doing really needs to be looking at the whole overall picture in order for us to get lasting relief from symptoms. So with IC and the microbiome, we know that changes in the microbiome might contribute to IC symptoms. Now, if we stop for a second and think about this, if a patient has had repeated treatments for IC that have included antibiotics, which are known to disrupt the microbiome, let's just think about how that might influence the progression or the management of IC symptoms. Antibiotics are a wonderful thing. Don't get me wrong. They save millions of lives every day. I use them in my practice often. However, if someone has had recurrent UTIs, let's say 4 or 5 UTIs every year, and they have a short course of antibiotics for that UTI each time, eventually, if there isn't repair to the microbiome through diet or through supplements like probiotics, it's possible that that might contribute to longer term IC symptoms or bladder irritation. We know that these imbalances in the microbiome can lead to increased inflammation and pain. So I want to make sure that we really understand that the microbiome component is very important to the health of the bladder overall. What is fascinating to me, and this never ceases to amaze me, is that we have studies to show that differences in the microbiome, there are differences in the microbiome of patients who have IC versus healthy individuals. So while we can't say this is what a healthy microbiome looks like in a patient without bladder symptoms, what we can say is that there are certain bacteria that are present in people with IC and they're not present in patients or people without it. So I think that's fascinating. And that's where the research currently sits, is that we know that a patient who has IC symptoms and the presence of Enterococcus, for example, within their bladder, even if it's not positive on culture, would lead us to think that there's an imbalance there in their microbiome. So the other piece about that is that we need, remember I was talking about that balance of good and bad bacteria. We know that there are bacteria in IC patients that are common to patients with bladder symptoms, but we also know that there are good bacteria like lactobacillus and Saccharomyces, that if those are not present, a patient can be more likely to be or more susceptible to chronic infection. That's a really important part as we get into the piece around chronic infection and testing. So I want to introduce this concept of the urogenital microbiome. It's sometimes also referred to as the Eurobiome. And this is talking about the bacteria that are specifically found in the bladder, urethra, and surrounding areas. So the vulva, the vagina, the anus, that's all included when we talk about the Eurobiome. We know that and this is going back to that previous point that I made, we have evidence to show that when certain Eurobiome bacteria are present, so we do a test, we see that certain bacteria are present there, a patient is more likely to have bladder and pelvic symptoms. So this is a really important part, and I'll talk about this further kind of in the next slides. I'm going to stop here for a minute and just see if with our Q&A, if there's anything there that anybody needed me to elucidate. So I'll talk about those, I'll answer these questions more when we get to our Q&A, and I'll move along now to current approaches to testing and current research. So I talked about this a little bit previously, but this point is really important, and so I'll make sure that we cover this in detail now. In the past, historically, we used to think that the bladder was sterile, so meant that there was no bacteria in the bladder unless you had an infection. We also used to think that bladder infections were only caused by a bacteria that was called E. coli. We know now that this isn't true. Other bacteria can cause bladder infection. In the 1950s, a medical doctor named Dr. Edward Cass developed a test called the standard urine culture to detect E. coli. And most of our modern culture testing for urine infections still rely on this principle. So we know that the bacteria E. coli can cause some bladder infections, but there are other bacteria that also can cause infection and are not well detected on a urine culture. And we now have research to support the use of a different type of test called PCR. There's a new theory that instead of our bladders being sterile, it's thought that the Eurobiome plays a role in whether or not a patient will develop IC symptoms or they will develop a bladder infection. And this idea is that believes or proposes that there are bacteria that live there all the time, good and bad, and urinary symptoms or bladder symptoms result when there's a shift in the balance of good and bad bacteria. So whether a person's introduced to a new bacteria from a hygiene issue like wiping, or an issue with a new sexual partner, or the person has had medication of some kind that caused urinary dysbiosis, that it's the overgrowth of the bad bacteria and insufficient good bacteria that can cause the symptoms to happen or to occur. And we know that this can happen, or the evidence for this is gained from evidence of how the microbiome works elsewhere in the body. So the key point about that is that if you have bladder symptoms and your symptoms of either infection or IC, and a urine culture is negative, it doesn't mean necessarily that there's no bacteria there or that there isn't some bacteria that is correlated with a disrupted microbiome or urobiome. So this is really important because we use urine culture currently to check if there's infection there and to tell a patient, nope, this isn't infection, it might be IC. But current research tells us that PCR does a better job, this different type of test does a better job of testing for all bacteria there and giving us a look at what's happening with our own personal microbiome. What's unfortunate is that where we are in our research and what's available, there isn't current urinary PCR testing available in Canada. I believe there is some available through hospital settings, but there isn't any in outpatient, so a practice like mine. I do run PCR testing, and we'll talk about what type of testing that is in a minute, but I send it to the United States in order to have that testing done and allow me to figure out what's happening with a person's urobiome. So just a little disclaimer about this. These are the tests that I use with my patients in practice. Other naturopathic doctors and functional doctors use these throughout the province. This isn't something that's only available here. It's also really important to work with your own medical doctor or a naturopathic doctor to discuss whether this testing is relevant to your particular situation and to make sure that you have someone that can appropriately interpret these results. So with each of my patients where IC is a consideration, I often will have a patient run what's called a Eurobiome test. So I use two companies in the US. One is called Microgen, the other is called Cirrus. This testing is expensive. It's anywhere between $400 to $600. And it's unfortunate that we don't have a Canadian option at the moment, but that's just where we are. What's beneficial with running a Eurobiome test is it's more accurate than culture to tell us what's going on. It will also give a list of bacteria that's present. So it allows us to see whether or not there's any or enough good bacteria there. It also looks for yeast and fungus. It will also help us to see how much bacteria is in your bladder. The benefit of that is that if you're having IC symptoms, and you want to know whether or not bacteria are playing a role or what's the health of your urobiome, a test like this can give you that answer. When the test is ordered by a medical doctor or a naturopathic doctor, it also gives antibiotic recommendations so that if they do find bacteria there, it allows us, or it'll give a recommendation for an antibiotic and then test to see whether or not there's resistance to that antibiotic with the bacteria that's identified. So that's a really important piece of ruling out whether or not infection or urobiome dysbiosis is playing a role here. There's also gut microbiome testing. So if the patient identifies as having IBS or other digestive symptoms, I'll use a test called the GI map. And a GI map, again, uses PCR to detect what's happening with the gut microbiome there. There's also other naturopathic or functional tests available. Micronutrient testing is something that I use often. So SpectraCell, excuse me, is a company that will provide testing for a wide variety of different micronutrients. So looking at iron, all your B vitamins, omega-3 status, as well as vitamin D. Vitamin D testing is available in the province through Life Labs. Sometimes it's covered if ordered by a particular specialist, sometimes it's not. And I'll talk a little bit more about vitamin D in a minute. But micronutrient testing that's private through SpectraCell looks at sort of all of the nutrients in one go. The last thing that I want to touch on is something called mycotox testing. So this actually looks for mold exposure. Mold exposure, so if you're living in a moldy environment, or perhaps you work in a moldy environment, or you know that you've had exposure to mold in the past, this can sometimes show up in your bladder. So it can sometimes show up as IC or as recurrent bladder symptoms. I see this often or relatively frequently in the Lower Mainland, just because we live in such a wet climate with many wooden buildings. But mycotox testing can tell us whether or not you've had exposure to mold in recent months, and whether or not that's a part of the picture for you. So there is also testing that's available through the conventional system, in which case I use Life Labs for this. But if you haven't had a urine culture and you've been given a diagnosis of IC, it can be a relatively easy to access, easy to run test. If it's negative, it doesn't always tell us that much, but if it's positive and you identify a bacteria there, it can sometimes warrant, or it often does warrant, treatment of that if it is showing up on a urine culture. Vitamin D. I know I've mentioned this a lot, but this is so, so important. Vitamin D plays a really important role in our immune health, in mood, in inflammation, in bone health, in kidney health. And so having your vitamin D tested so that you can have an appropriate dosage recommended to you is really critically important. We know that, as I mentioned before, 75 to 250 is the reference range of what we would expect to see on a Life Labs result. But for all of my IC patients or patients with recurrent bladder concerns, I want to see that vitamin D level at a bare minimum 125, ideally 150. I also like to look at a thyroid panel. This is an important picture of overall health. I like to run TSH, T3, T4, and TPO antibodies. TPO antibodies look for a particular type of thyroiditis called Hashimoto's, and it's important to me. That's an autoimmune type of thyroid, so it's important to me to look at the entire picture. It gives me good understanding of what's going on with your overall health. I have had, moving on to celiac testing, this is also a really important one. If a patient is celiac and doesn't know it and is consuming gluten on a regular basis, I find this often shows up as inflammation within the mucous membranes. So within the mouth, the bladder, the vagina, the gut, it will often show up as other symptoms, but ruling out celiac in a patient with IC or bladder symptoms is really important. A hematology panel, this is sometimes also will show up on a Life Labs report as a CBC and differential, complete blood count and differential. This is important to see what's happening with your white blood cells overall. So I like to look at a hematology panel to see, okay, so we've had a culture, it was negative, but a person's white blood cells are elevated. Are we dealing with infection here that hasn't been identified? Are we dealing with a bit of inflammation? It helps me put part of that umbrella picture together. I also like to look at iron. Again, the reference range for iron, the bare minimum through Life Labs testing is 15. But for many of my patients, I like their iron levels to be between 60 and 100. That's less relevant, I would say, or it's still relevant to IC, but it's more part of the global overall picture. Same thing with vitamin B12. I usually like to see B12 in the neighborhood of 400 to 500 when I'm testing. Blood sugar testing is really important because often a symptom that can show up of diabetes or pre-diabetes is frequent urination. And so when considering whether or not a person's IC symptoms, part of that umbrella that I want to rule out, I want to look at their blood sugar. So hemoglobin A1C, fasting glucose, insulin, to make sure that this isn't actually diabetes showing up as a bladder symptom that I'm missing. I like to look at kidney function testing, so creatinine and GFR, amongst other things. This helps me to have an understanding of, is this patient working with reduced kidney function? And that's why we're seeing bladder symptoms showing up, but that's an important one as well. And then lastly, CRP, or C-reactive protein. CRP is a general marker of inflammation within the body. And so it helps me to, again, piece together that overall picture of what's happening with a person. Just as a reminder of that, this disclaimer, this should not be taken as an absolute be all end all. And anybody that is seeking these tests through an MSP based provider, it's up to the provider, their discretion, whether any or all of these are relevant. So this is what I tend to run in my patients. But I'd encourage you to speak with your care provider and make a decision whether all of these are relevant or just some of them are. So moving along to treatment options. So as I mentioned before, that when it comes to treating, I see from a naturopathic perspective, I often like to think about things from a lifestyle perspective. I'll think about them from a medication perspective, a pharmaceutical medication or prescription perspective, and then I'll think about them from a supplement perspective. What are the three? Those are sort of the three categories that I like to think about. And I often like to draw from all three when creating a treatment plan for someone, to make sure that we're covering all of our bases. So as I mentioned, pelvic floor physiotherapy is a really important one, and we are completely so fortunate in BC, both on the island, in the interior, in the Lower Mainland and elsewhere, to have access to really good pelvic floor physiotherapists. Many physiotherapists during COVID also switched to offering telemedicine or online visits. So even if you don't have someone in your community, I'd really encourage you to find someone that you could see for pelvic floor physiotherapy, even virtually. Even if they say, I've done my assessment and everything looks good, it helps you to rule out one spoke of that umbrella so that you can be confident that that's not a part of the contributing factors to your bladder symptoms. Correcting nutrient deficiencies. So again, I'm repeating myself, but this is so important. Getting that vitamin D to between 125 and 150 minimum is really important. Correcting other nutrient deficiencies like iron and B12 are also really important to overall health, but making sure that that vitamin D is sufficient is really, really important. Working on reducing inflammation. So naturopathic doctors, dietitians, nutritionists typically will have resources on how to support an anti-inflammatory diet, how to reduce inflammation. So looking at other lifestyle factors like alcohol, tobacco, drug use, working towards really reducing that overall inflammation within the body. IC can sometimes be an inflammatory response. So getting that under control is really important. And then the last piece is managing those co-conditions. So working with someone to make sure that you are correcting constipation, treating mold, if that's a part of the picture for you, or addressing those hormonal symptoms. So meaning that you are, I gave the example with vaginal estrogen in perimenopause and menopause, having someone that can get you that vaginal estrogen and managing those symptoms for you is really important. So treatment options from a supplement standpoint, there are, would be foolish if I said that this isn't a complete list, but these are sort of the top 4 products that I use in my practice, and then one that I don't use very often. When it comes to supplements, it's truly the Wild West out there. Lots of what's available on the counter isn't strong enough, or it requires you to take quite a bit to get the same effect. Pure Pharmacy is a great place to get access to what we call professional line supplements. So products that are really good quality, are tested by third-party pharmacies or third-party laboratories. And that can be an excellent resource for you to get access to a good, I don't have any shares in Pure Pharmacy, but it's often where we send patients to get access to good quality supplement products. What I will do in each of these categories is talk about what I look for with probiotics, for example, D-mannose, aloe, and uva ursi. And I'd encourage you to take the principles of what I'm recommending to review or look at what you may be able to find in your own community. So when it comes to probiotics, what I find a lot of what is out there is generally speaking too low a dose and not enough strains. So what that means is when you come across a bottle of probiotics or a box of probiotics, you want to flip it over and take a look at the back. When a person is dealing with IC symptoms, I recommend that you want to be looking for between 50 and 100 CFUs per capsule. So what that means is that within each capsule, there's 50 to 100 billion colony forming units. That's how much of that probiotic is in each capsule. That's the first important thing to look at. The next important thing to look at is that it is multi-strain. So often I find my patients who have IC symptoms look for a probiotic that says Women's Health or UTI Health. Usually that contains two particular strains of lactobacillus called Lactobacillus rhamnosus and Lactobacillus reuteri. But what we actually want to be looking for is a broader spectrum probiotic than that. At minimum, we want to see 4 strains there. It's ideal if one of those strains is something called Lactobacillus plantarum, Plantarum, Lactobacillus plantarum. This is really important because Lactobacillus plantarum is a probiotic, a good bacteria that is known to set itself up in the digestive tract and attract other good bacteria from our food, from other supplements that we're taking, from other microbiome support or other probiotic rich foods like kombucha or kefir, sauerkraut, and other fermented foods. A probiotic that contains Lactobacillus plantarum is really, really important. So that's one way to assess probiotics in your own community. Often with a patient with IC, I will recommend 2 different types of probiotics. One being a good quality, high potency, so between that 50 and 100 billion CFUs, broad spectrum, so lots of at least 4 strains probiotic. And then I will also recommend a women's probiotic on top of that. And that's that women's probiotic, we'd be looking for something that has Lactobacillus rhamnosus and reuteri. So that's kind of my overview of probiotics. A question I get often is, if I'm on antibiotics, should I take my probiotics? And the studies show that yes, you should continue to take your probiotics, but it should be separated by at least 2 hours. So if you're on an antibiotic twice a day, for example, morning and evening, you take your probiotics at lunchtime. This, again, something you should discuss with your care provider, but this is generally what I recommend. When it comes to D-mannose, this is a really interesting one, especially right now. There was a recent study that found that D-mannose was not effective. And when we look at that study, we find that it was not a very large study. It had a small sample size. And when I looked into the details of it, what I found is that the dosage of D-mannose was 1,000 or 2,000 milligrams in the 2 different groups. And I find with D-mannose, it's commonly recommended, but most of what's available over the counter is in that 1,000 or 2,000 milligram dosage. I find for D-mannose to be effective, it really needs to be in a 3,000 or 4,000 milligram dosage. Now, D-mannose is a tricky one because if you suffer from loose stools or IBS-D, IBS diarrhea type, D-mannose can worsen that. So a higher dosage of D-mannose can especially worsen that. I typically recommend that you start out with a week or 2 at the lower dose and then work up to 3,000 or 4,000 milligrams. But with D-mannose, I find it is quite effective. And we do have some studies to show that E. coli, it's effective against E. coli, And there was a study published last year to show that it was effective against Klebsiella as well. The trouble was when they moved it into a patient population, they just had a small sample size and insufficient dosing. So D-mannose is one that I really recommend. Aloe. So this is another product that I recommend often to my IC patients. Whether or not there's an infection, an infectious cause, an inflammatory cause, a hormone cause, aloe is a very soothing herb. And this is something that we can use in capsule form. It comes in gels and drinks and all kinds of different things. I typically recommend it in capsule form, and this is something that you would take orally. Aloe is very soothing to the bladder, and I find it can really help to rapidly reduce that inflammation. Uva ursi is a herb, and this is a herb that I use often in my patients where we've done a Eurobiome test and we've identified bacteria there that needs to be treated. So this is really best done under the guidance of somebody that has herbal education. So a herbalist, a naturopathic doctor, somebody who knows what they're doing, but uva ursi can be a very helpful herb to use in that case. The last thing I'll talk about is cranberry. And so this is one, excuse me, that is always a little bit controversial. Cranberry, I find, is regularly recommended for recurrent UTIs, interstitial cystitis, chronic bladder symptoms. But what's interesting is when we look at the research for cranberry, it's actually not very strong. So this isn't something that I recommend regularly in my practice. For most patients, there's no harm in taking it, but I don't find that it actually does very much in terms of management of symptoms. There is some support for it in terms of prevention, but I don't feel like the evidence is strong enough to warrant somebody taking cranberry on a regular basis. This also means that if you have symptoms of UTI or bladder symptoms that are showing up, buying and drinking some cranberry juice is not really what's going to help. You'd be better served by getting your hands on some aloe. So let's talk briefly about treatment options from a pharmaceutical perspective. Again, these should all be discussed with your primary healthcare provider or your specialist as well. But these are some of the things that I use in my practice. So I mentioned vaginal estrogen. Many people can feel worried about exposure to estrogen, but vaginal estrogen typically is given in a 10 milligram dosage. It's usually inserted within the vagina or a cream that is applied. And we know that vaginal estrogen is not the same as systemic estrogen. So if you're someone that's going through perimenopause or menopause and you've been given a patch or a cream or another way of using systemic estrogen, vaginal estrogen is different from that. Again, a decision to be made between you and your healthcare provider, but this is something that I've seen has made a huge difference in many patients' bladder symptoms when they're at midlife. LDN or low dose naltrexone, this is another pharmaceutical that I use very often, and I believe that it's used often in the CC, the complex chronic disease patient population. LDN I typically use as a way to lower overall inflammation, and I find that it's particularly helpful when it comes to the bladder, both in non-infectious causes of IC and infectious causes of IC. It seems to just cool off the immune system enough that we can actually get a patient feeling quite a bit better. I do use antibiotics in my practice, especially if we've identified something on a Eurobiome test that leads me to think that there's something there that we need to treat. So that's something that I will use under the guidance of what that PCR testing is telling us. Kiprex is a really interesting medication. It is not a urinary antibiotic. It is a urinary antiseptic. So what that means is that it creates an environment within the bladder that's very difficult for bacteria to grow. It mixes with the acidic environment of the stomach and then turns into something that makes it hard for the bacteria to grow in the bladder. It's a very safe medication. I've found that it's actually very difficult to get in Canada. It's prescription only. It's more readily available in the United States than the UK, but I've been working with my local pharmacies as best possible to try and have it more available here because it's a really, really interesting medication and I've seen it make a big difference in many patients' lives. Other treatment options when it comes to pharmaceutical approaches for IC primarily target pain. Many of you might be familiar with a drug called Almiron. This was available, it's still somewhat available, but it was around far more prevalent a few years ago. But there was a study that came out that showed with Almiron, there was a link between Almiron and glaucoma. And so I'm finding that it's not as frequently prescribed currently. And many patients who were previously on it have made the decision with their care provider to come off of it. That's not to say it's right for you, it's just warrants a discussion. So I believe that takes us to the end of our hour. I will jump into the Q&A right now. Just make sure that I am covering everything properly. So I can see that we have 25 questions. I will do my best to cover that in the next half hour. Thank you so much for your participation. It means a lot to me that you have these questions coming up. So what I'm going to do, I'll just start with the questions from the beginning. What I will say too is that I won't be able to give specific medical advice today, but I will do my very best to answer what I can today. So starting with the very beginning, so this looks like there's some symptoms that happen that are very minor, and that there's, it sounds to me like potentially a little bit of support needed there. I'm just gonna make sure that I'm covering these. Yeah, okay, good. Just making sure I'm not missing anything technical here. So with this, and what I might do actually, just to make sure that privacy is maintained, I might stop the screen sharing. Give me just a minute here. Oh no. Okay, so maybe somebody let me just know in the Q&A that I'm still here. Okay, I'm good. I was really worried that I left the room, but I just wanted to make sure that I covered everybody and was hiding privacy. So thank you for all the thumbs up. I really appreciate that. Okay, so let's go in. So it sounds like somebody had some questions about basically some more minor symptoms that were showing up. And it sounds to me like there might be a little bit of pelvic floor dysfunction there. So with someone that this person wasn't sure if it was IC, they didn't have a diagnosis, I would really recommend having an assessment with a pelvic floor physio, because I do think that that would really help to see what's going on with those symptoms there. So another question that I had is, have I ever seen the use of Plan B and intercourse, first intercourse as a trigger? I absolutely have. So when you think about Plan B, less so, but Plan B is very similar to taking a higher dose of hormone all at once. And we know that hormone symptoms can trigger bladder symptoms. So absolutely with Plan B, yes. Also with intercourse. So we know that intercourse has a number of possible causes of why it would be playing a role with IC. One is that it's introducing somebody else's skin microbiome and potentially semen microbiome into your environment. And so if you're not, if you're in a state of dysbiosis, that can be a trigger. But it can also be a trigger from a pelvic floor perspective. So from intercourse, as you can imagine, there's lots of friction, there's lots of movement. That can absolutely be a trigger there. So I would encourage you to work with your care provider, A, to assess the hormonal piece, B, to assess the microbiome piece, and C, to work with a pelvic floor physio to see if there's anything there that could possibly be a trigger. So great question. I love this. Why should we trust a naturopathic doctor, especially with all the misinformation that can come from alternative medicine? Love this question. Thank you for asking that. So just as with every profession, there are all types when it comes to alternative health and naturopathic medicine. I typically, what I would recommend is that you're looking for somebody who is licensed and registered. So the BC Naturopathic Doctors Association, the BCND, is a good resource for you to look for someone who is licensed. It also is important. Most naturopathic doctors offer discovery calls or meet and greets. So I would potentially think about booking with somebody and asking them about, what's your background? How do you treat this? Do you see a lot of IC patients? As I mentioned in the beginning, I wanted to make it very clear what my approach is as a naturopathic doctor, that I try my very best to blend the best of conventional and naturopathic worlds. So because I actually think that's where patients get their best care. However, not all naturopathic doctors practice the same, just the same way not all dentists practice the same, or physios practice the same. So I think it's valuable to talk to people in your community and ask the provider that you're going to see, do you prescribe? Do you use lab tests? Do you, or is there something that you do that's more energy healing based, for example, which is wonderful and amazing, but very different from what I do. So two answers to that question. One, it's important to find somebody that you do trust and is providing the type of care that you're looking for. And two, talking to the association in your province, so in BC, for a licensed and registered naturopathic doctor. I would hope, and I would just put it out there, that some of the information that is available online in the alternative health space is not coming from licensed and registered NDs. I'm sure some of it is, but hopefully most of it is not. And most of the NDs that I know that practice in this community are very evidence-based. So great, next question. I was told that estrogen for migraine with aura, wondering if vaginal estrogen would also be contraindicated. Loving these questions. So no, it is not contraindicated. However, your case might be particular. So it's important to review that with your own care provider and with the prescriber of that vaginal estrogen. I have a whole questionnaire that I take patients through. However, keep in mind, vaginal estrogen is not systemically absorbed. At the dosages that we give, it is not systemically absorbed. So the other piece about that is there are good alternatives for vaginal estrogen in a patient who can't take it. So Pure Pharmacy has a woman named Shirley Weir from the Menopause Chicks formulated an awesome vaginal moisturizer with hyaluronic acid that has similar results to vaginal estrogen. So if you're a person that can't use vaginal estrogen, you and your care provider have deemed that's not a possibility, you could use, there are alternatives out there, and I would talk to a pharmacist at Pure about that. Next question. I've had IC for over 40 years and would suffer like crazy, lots of smell because of infections, more stable now because I cannot control my bladder daily. So great question. I would say for the bladder control, definitely think about seeing a pelvic floor physio. I have many patients in my practice who have had this condition for 20, 30, 40 years. I do also think that it might be worthwhile for you to talk to somebody who could look at microbiome testing or potentially look at whether or not you'd be a candidate for vaginal estrogen, because if you've had this for 40 years, it means you've been alive for 40 years, which means that you'd be kind of in that midlife group. My urine keeps showing leukocytes and red blood cells, so white and red blood cell positive, but the culture shows skin flora. One of my favorite questions. Skin flora is reported from the lab when there is more than one bacteria identified. The lab considers that a contaminated sample, but what it actually means is that there's multiple bacteria there. I would argue, this person's asking, what do you think it is? I would argue that you need a PCR test, because we need to know what that bacteria is. And if what's being reported as skin flora includes some of the bacteria that's associated with IC, it needs to be identified and treated. And my hope is that in the next 5 to 10 years, this will be standard of care. So meaning PCR testing would be standard of care. It's just not yet. Can vaginal probiotic suppositories help with IC? Absolutely. So if a patient comes in with IC symptoms and they're also having vaginal symptoms, I'll consider whether that Eurobiome test is important. That Eurobiome test looks at two samples, one a vaginal sample and a urine sample. So I would think about whether or not that's something that we want to do for that person, but generally speaking, vaginal probiotics are quite safe if they're formulated with just the probiotic. And there's a great one formulated by a company called NFH. So is naturopathic medicine now covered by MSP? I'm sorry for the miscommunication or the confusion there. It is not. So the naturopathic medicine is not covered by MSP, which means that it's just it's private pay or covered through extended health like Pacific Blue Cross, etc. Another excellent question. Does the use of incontinence pads impact the microbiome? So I can't say that I have any studies or research on this, but we do know that the use of certain types of underwear can impact the microbiome. So synthetic underwear that's made of polyester, for example, versus cotton underwear, we know that that can impact both the vaginal and bladder microbiome. So I would say yes. Incontinence pads are a tricky one because they typically are worn all the time. If you're home and can give yourself a break from them, I think that's a really good idea. I also think that it's worthwhile to think about incontinence pads that are made from better fibers. So organic cotton if possible, or some of the companies, there's a great company called Some Days in Vancouver that makes like a cloth cotton pad that can be used. Depending on the degree of incontinence, it's not always sufficient, but it's something to explore. And again, I'd encourage you to speak to a pelvic floor physio, even if you've had incontinence for a long time. So the next question is, these are all such great questions, so thank you for your participation. Can eating disorders increase the risk of developing IC? I don't have particular data on that, so I don't have a study to say so. But what I have seen prior to working with patients with bladder issues, I had and I still have a broad spectrum women's health practice, and I saw many patients with eating disorders. And what I noticed is that as opposed to it playing a role in bladder health specifically, I found that having an eating disorder can play a role in microbiome dysbiosis. So if we're having restricted eating and we aren't feeding our microbiome because our good bacteria feeds on the fibers in our food, if we don't have enough good food in our diet to feed the good bacteria, that can worsen the microbiome, lead to dysbiosis, which could potentially lead to IC. It's a few steps along the way, and I wouldn't say that that's the case for everyone, but I would say it is a possibility. So is IC different from a diagnosis of an overactive bladder? It is a different diagnosis. Usually if overactive bladder is present, it often means that a person is going to the washroom frequently in the absence of other symptoms. There are medications for overactive bladder that I see commonly prescribed in IC, but I would say that I'd still be looking for a root cause, because both of those to me are the diagnosis, but not the understanding of where this came from in the first place. The next participant asks about, I've had 3 cystoscopies over the past 3 years and they were all normal. So just so everyone knows, a cystoscopy is where a specialist will insert a camera up the urethra to look at the bladder and see if there's anything there that would be a cause for bladder symptoms. Each urine test shows no bacteria. I continue to have constant burning and I've started vaginal estrogen twice a week, still have burning and discomfort all day. Do you have any recommendations? I'm postmenopausal. Again, I think you'd be a really good candidate, or this person would be a really good candidate for Eurobiome testing. So taking a look at what your microbiome is doing and seeing, are there commonalities in IC patients? Are there things there that we should really be treating with antibiotics or other medications? But that really I think because that urine testing, which is the culture, is showing no bacteria, given that you've had the constant burning, I'm suspicious that there could potentially still be bacteria there. Yes. So could I mention the costs of the additional tests? Some of them are really expensive. So the Eurobiome testing can range in the neighborhood of $400 to $600 Canadian. A GI map is similar. It really is a hard thing for me that we don't have access to this in Canada at the moment, and that this isn't standard of care. But I know our medical system is doing the best with the resources that we have. So at the moment, that's what we have. But hopefully we'll have some answers soon. I've been working with Life Labs to see if that's something that we can potentially pull together. And I would say that the mycotox testing are similar costs, somewhere in the neighborhood of $400 to $600. It's a lot. And I would say the caveat to that is I rarely, if ever, recommend that you would do all of this, really. What I would recommend is that you would work with a provider to look at determining what's the best for you and then making a decision if that is something that you could do. But a provider should be able to provide you with information, even if you're not able to do the testing. So we will use whatever tools are available. So great, another good question. What are some solutions for mold exposure? Really, when we look at mold exposure, piece number one is to find out where the mold is coming from. So are you living in a living situation where there was a leak in a bathroom that wasn't repaired and there's mold growing there? And maybe that warrants a move or mold remediation within the environment. When a person is having symptoms related to mold exposure and we see that on a test, often we'll look at really strong antioxidants like glutathione and acetylcysteine, working on helping the liver really eliminate the mold toxins from your system. Usually in this case, I'll refer a patient to someone who works more with mold. We have someone here, Clementine, that does, but works more with mold to help have somebody recover from that. Can we get a lot of blood? Another good question. Can we get a lot of blood work tests through our family doctor and then send to a naturopath? I don't encourage using your family. This is a really good question, but I really don't encourage using your family doctor just for testing. So really, when it comes to testing, it's a family doctor's decision whether or not, when they're giving you a test, it's their decision whether or not they think it's important or think that it's warranted in your case. But a prescription written by a nurse practitioner or a family practitioner, family doctor, is usually covered under MSP, whereas testing, if I order a Life Labs test, it's not. So it's up to you, but I don't generally encourage that. I encourage you to speak to your family doctor about what's going on. So what was the numerical level of vitamin B12 and iron that you look for? Great question. B12, I like to see between 350 and 500. Iron, I like to see between 60 and 100. So hopefully that helps to answer there. 350 and 500 for B12, 60 and 100 for iron. What treatment options do you suggest for IC patients with Hunner's ulcers? You've mentioned a number of possible causes for IC in general. What would be the causes for recurring Hunner's ulcers? Great question. This one's very specific. Often when I see Hunner's ulcers, it really makes me think about what's happening with the immune system. Is there autoimmunity here? Is there something happening where we need more support from an immune perspective? So usually I go back to the basics with that. What's happening with vitamin D? What's happening with diet and digestion? What's happening with hormones? Really, to me, the Hunner's ulcers are a symptom of a deeper sort of imbalance that's going on. And sometimes it could be potentially a dysbiosis component there. So hopefully that helps to give you a little bit of an overview. It's not that as specific, but hopefully that gives you some information there. Should you take supplements like D-mannose or cranberry preventative, or only when you have symptoms like UTI? So this really depends on a particular case. Often I do, if a patient has frequent symptoms of IC. So there's sort of two things to think about here. If a person has symptoms of a UTI, but their test is negative, but they feel the urgency, the burning, the frequency, the smell, they have, like the case we saw before, positive white blood cells in the urine, I will have them on D-mannose all the time. If a person, say 3 or 4 times a year, they have intercourse with a particular person and they get symptoms after that, you could use D-mannose in that case on a case-by-case basis. If this is someone who has an IC diagnosis that has some sort of bladder symptom on an ongoing basis, I typically recommend that you be on D-mannose all the time as a preventative. And again, at that higher dose. I find 1,000 to 2,000 milligrams just isn't enough. We need to be on closer to 300 to 400 milligrams. The next question was somebody asking, they saw a specialist and someone asking if it possibly could be cancer, but that was ruled out. I would say that our medical system and specialists do an amazing job of ruling out cancer. So if you've had that assessment and had it twice, I think you could feel very confident in that answer. So do you treat any men with IC? I do. And it's a little bit more particular. I focused our talk today mostly on women because it tends to affect the female population most often. But I do find that there is a correlation, or that men, I have a number of men in my practice with IC. It's important to keep in mind that with men, our anatomy is quite different, right? So instead of the bladder sitting right next to the uterus in women, in men, the urethra that takes urine from the bladder to the urethral opening, so to the end of the penis, goes through the prostate. And so it's a special consideration in men where we want to look at what's happening with the prostate. We look at that in terms of age, a particular blood test called PSA, prostate-specific antigen. Could there be an inflammatory condition in the prostate? But the prostate can also become infected. So you can have something called bacterial prostatitis, where there is bacteria in the prostate itself. With that Eurobiome testing from Microgen, there is a test to look for prostatitis as well as urinary bacteria. So it's a very important thing to think about. And I apologize that my talk was more centered on females. But yes, absolutely, in the male population, this can show up frequently, and especially with age. So after one has gone through andropause, I find that it can show up quite a bit more frequently. I found antihistamines have been helpful in reducing bladder irritation. Is there a connection between IC and MCAS? Yes, so it's interesting because there was a theory proposed probably 5 or 6, longer than that, years ago, about the gag layer theory when it comes to interstitial cystitis, or IC. And this idea was that there's a layer within the lining of the bladder that can become inflamed, and that's where IC symptoms come from. So there is a correlation between, or that's where antihistamines can be beneficial. And that's part of the standard conventional treatment, actually, is using antihistamines to reduce the bladder irritation. If they're helpful, I think that's great. They're not a standard part of my recommendation because the gag layer theory has been questioned in the research lately. But yes, there is a connection between IC and MCAS. And this particular question is asking if I ever use something like quercetin. Yes, I do. So that's part of that inflammatory component that I look at. I'll often use aloe before I use quercetin because I find that quercetin doesn't have the same impact that aloe does. But this is absolutely something that can be really beneficial. So if you have MCAS and you're thinking that your IC might be more of an inflammatory response than an infectious response, that's again going back to that umbrella, it could be worthwhile talking to your care provider about doing a trial of something like quercetin. The next question is very similar. I have mast cell activation syndrome, chronic fatigue, POTS, and IBS. Benadryl has helped, and so is baking soda in an emergency. So baking soda is a common thing that many patients will use in the absence of having Benadryl or an antihistamine. What baking soda does is it neutralizes the acid in the bladder, and that can help to reduce the inflammation. This person made a really important point. I don't have money for expensive tests. And it's an expensive thing to see a naturopathic doctor too. So I really, really relate to that. I think in that case, I'd probably be more inclined to think that this is an inflammatory response as opposed to an infectious response. And I would also look deeply at what's going on with the IBS. So there's lots of things that you can do for IBS without expensive testing. And I would look at, what's your IBS? What are your symptoms there? Are they constipation based? Would it be worthwhile to work with a pelvic floor physio or assess what's happening there? But given that you have the MCAS, the CFS, the POTS, I would say it's probably likely that there's an inflammatory component there. Another one, I take macrobid when I can't control my bladder. I would have major accidents. So this is not an uncommon thing to be prescribed an antibiotic to take as a one-off, but I think it sounds like you probably would want to meet with someone that can give you an assessment of kind of what's going overall. This is another really good question, what if probiotics aggravate IBS symptoms? So again, that can definitely happen. You don't need expensive testing for this, but I do think it's worthwhile to figure out where the IBS is coming from and why you're reacting to that. A reaction to that probiotic. A reaction to a probiotic can often be an indication of dysbiosis within the digestive tract. So if you're someone that takes the probiotics and you get sort of heartburn type symptoms, that gives us information in one direction. If you are someone that takes probiotics and you have a reaction that's lower down where you're having gas and bloating, that gives us other information. But all of those are clues to kind of come back to what's going on with your digestive tract. What I would say too is that if probiotics aggravate your IBS, looking at the quality and the quantity of fiber in your diet is a really important piece, particularly soluble fiber. So things like fruit fibers, like apples and cherries, and then looking at things like chia and hemp and flax as also really good sources of soluble fiber. Is overactive bladder the same as IC? I answered this one above, but they are different and they do have different treatment approaches. Can I restate the supplement provider I trust? Sorry, I'm speaking quickly. Pure Pharmacy. So in BC, Pure Pharmacy, there's lots of locations throughout the Lower Mainland. There's a location on the island, but they also ship. So it's a really good quality pharmacy where you can access good quality supplements there. A brand of aloe that I recommend. So I really like the Designs for Health brand. It can be a little bit more expensive, but they have a really good, very potent aloe. I think it's called Aloe 200X. More widely available is the Desert Harvest aloe. This is very popular in the IC and bladder health community. It's Desert Harvest. There's lots of providers that, or lots of places that you can find that online. I've used grapefruit seed extract, citricidal before. What is the current thought on this? So citricidal used to be great. It was something that I would recommend to my patients, but there was a study published that looked at grapefruit seed extract and its antimicrobial or bacterial fighting properties. And what they found was that grapefruit seed extract alone didn't have much of an impact. So I would say it's probably not harming you, but it's probably not strong enough to treat bacteria in the bladder. I didn't mention cystoscopy as a diagnostic tool. Do I recommend it? I do recommend it if it's something that your care provider has suggested. So if this is something that you've seen a urologist and they want you to do a cystoscopy, I'm never going to tell you to do something that your specialist has not recommended. However, I find that if you've had a cystoscopy and ruled out whether there's something structural, you don't have Hunner's lesions, you don't have bladder cancer, there's something else there that we need to see, it's probably not something that's worthwhile repeating unless there is something that you want to kind of continue monitoring. I do find when it comes to infection or inflammation, it often doesn't show up on cystoscopy. So it's not a diagnostic tool that I would recommend unless I have other concerns. Okay, great. I'm really glad you can't. Thank you to the person that you can't see the questions so that privacy is given. I was really worried about that, so thank you. Can I restate the 2 lactobacillus strains that should be found in a good women's health probiotic? So I'll talk about the 2. The broad spectrum probiotic, you want to look for Lactobacillus plantarum, L. plantarum, Plantarum. The women's health probiotic, you want to use, and I'll just look up briefly exactly how to spell this, but Lactobacillus rhamnosus and reuteri. And rhamnosus, I believe, is RHAMNOSUS, RHAMNOSUS, and reuteri is REUTERI. I'm probably saying it incorrectly. REUTERI. So those are the two. Do urologists treat IC? They definitely do. They probably have a different approach to how I treat IC, but urologists, absolutely, this is in their wheelhouse. Does vaginal estrogen impact endometriosis in pre and post menopause? Great question. I will use vaginal estrogen in patients with endo. I find it doesn't have an impact. I know that with endo, there's often concern around overall systemic estrogen levels, but I want you to think about vaginal estrogen similar to a face cream. Like, it's really only treating the local area. So hopefully that helps to answer that question. Any recommendations for IC caused by dysautonomia? Lots of peeing. So this is probably one that I would focus A, on inflammation, and B, on what's going on within the actual, within the pelvis in terms of how organs are relating to one another. So you might think about, it sounds to me like some of the messages that are getting through to your bladder are too frequent. But when we think about dysautonomia, I think about it sort of as an overall picture of there are too many messages happening too frequently. So I would be looking in terms of the umbrella for someone with dysautonomia, what's happening with the nervous system, what's happening with cortisol, what's happening with the energetics within the body, what's happening with sort of that mindfulness piece, and then also making sure that the pelvic floor is in really prime shape, so that we're not finding that, for example, there's some nerve entrapment that's causing a bit of the triggering of the nerves on a more regular basis. So looking at sort of a whole, more of a holistic approach. Thank you for your talk. Is double voiding associated with IC? Thank you for your thank you. It can be. So void, what that means is that someone's peeing and then they stop and then they pee again. I'd be very curious about pelvic floor. Very curious about pelvic floor with double voiding. And I know we're coming right up against the hour, so I will get through. I just have a few more, so I'll get through as many as I can. Diagnosed with IC in my 20s, I'm 46. Vaginal discharge has been very annoying, seems to be worse every time. My IC symptoms are worse. Never had any explanation for the vaginal discharge. Is it possible it's related to IC? Dysbiosis. I would put my finger on it, dysbiosis. So I would take a look at what's going on, vaginal symptoms, what's going on with your IC symptoms and any digestive symptoms, and see if you can correlate them, because I bet you there's an imbalance there in the microbiome. If you don't have money for testing, you have skin flora show up all the time. How should we trial D-mannose and aloe? Caveat. So this person is saying no money for testing and skin flora shows up all the time. Should we trial D-mannose and aloe? So yes, work with your care provider. Definitely run it by your doctor. Take a look at that. But if you have skin flora showing up repeated on culture, I'd be very suspicious that there's some dysbiosis there and bacteria that shouldn't be there.
I'm afraid we're out of time.
All out of time. So only 3 left. But if you want to send those questions somehow, I'd be happy to answer them in an email.
Thank you so much. Are you okay if we share your slides with the group?
Absolutely. Absolutely.
Yeah. So when Bruno and I get back, we will send the slides. Thank you. I learned a ton. This is great presentation.
Oh,
Have a good
thank
week,
you.
everybody.
Thank you for having me.